Thank you. Myself and Karen today are presenting on behalf of the Guidelines Development Group, who produced these guidelines, which was chaired by Kirsty Roy. Just what I'm going to cover in this presentation is a bit of background, some of which Gillian has also explained in her presentation, the rationale, terms of reference, and intended users for the guidelines. Karen's going to cover a bit about the guideline development process, so the sort of literature searching and evidence base that underpins the guidelines. And then I'll talk a bit about the guidelines, where they are now. They're essentially a finalized draft, they just need signed off. And I'll just be talking about certain sections of them. It's currently a 70-plus page document, so I've had to distill it into a presentation, so I'm obviously not covering everything in them. So tetanus, botulism, and anthrax are the illnesses that are caused by spore-forming bacteria. So you just heard that spores are widely found in the environment. We think that these spores contaminate drugs, which is how people who use drugs become infected with these illnesses. So they get into the drugs somewhere on the transport route or during the production of the drugs, potentially through the introduction of cutting agents at various stages. And people become infected when they inject these drugs because the spores germinate, cause a localized infection initially, but ultimately they can cause severe illness and death. So in the UK, prior to 2000, we actually hadn't seen very many cases associated with these spore-forming bacteria at all. And from 2000 onwards, we saw an increase in these infections. So as Gillian mentioned, there was the C. novii outbreak in 2000. There have been tetanus and botulism outbreaks, including the most recent one in 2014, 2015. There have also just been sporadic cases, and of course the anthrax outbreak in 2009 and 2010. So interestingly, as has been alluded to already, I think in the UK we tend to see higher rates of these infections than in other neighbouring European countries. We're not exactly sure why this happens. The UK could be one of the sort of at the end point of the where the drugs are travelling to, so has the most potential for contamination. But we also see higher rates of infection in Scotland within the UK relative to England. So this is map is just highlighting with the darker areas some of the areas where we see increased rates of these infections in Scotland. So the rationale for the guidelines is that because we can't really do anything about the quality control of the drugs that are coming into the countries, and these spores are widespread. We keep seeing cases, so contamination is considered to be ongoing, and there's potential for future outbreaks. So there is a need for guidelines. It was also felt that much experience has been gained from previous outbreaks, and this just needed to be gathered together and documented in one place. So just to note with regard to these infections, they have typically infected people who inject drugs, PWID, PWID. However, in the anthrax outbreak, there were several cases associated with that outbreak where they didn't report injecting, so we couldn't exclude the possibility that infection had been acquired via smoking or snorting drugs. And inhalational anthrax is, of course, a recognized clinical type of anthrax. So the guidelines throughout refer to people who use drugs rather than people who inject drugs. So PWUD, I guess, is that acronym. A little bit strange sounding. So the Guidelines Development Group was tasked with developing this guidance for the public health management of incidents and outbreaks involving the contamination of legal drugs with these three specific bacteria: Clostridium tetani, which causes tetanus, Clostridium botulinum, which causes botulism, and Bacillus anthracis, which causes anthrax. C. novii wasn't included at this stage because we haven't seen any C. novii cases since the outbreak in 2000. But of course, the principles of these guidelines could broadly apply to any incidents or outbreaks associated with those kind of spore formers. So in scope were the operational aspects for managing incidents and, of course, public health interventions that could prevent or mitigate the impact of infection with these bacteria. And out of scope was the clinical management of cases. And just these guidelines weren't clinical, and also this has been well documented elsewhere. So the aim in terms of users, the target audience for these guidelines, is essentially anyone involved in incidents associated with spore-forming bacteria. So frontline staff are key, whether in hospital, addictions, injecting equipment provision services, primary care staff who might come into contact with infected people who use drugs, consultants in public health medicine, who are obviously key in the public health response, consultants in microbiology, consultants at Health Protection Scotland, police and criminal justice, and third sector agencies. And I'll just hand you over to Karen, who's just going to talk a bit about the guideline development.
I want to sort of briefly give you an overview of how the process kind of went about. Broadly speaking, for the whole guideline development, there's 5 stages. In particular, stage 3 is the stage I'm going to talk about, and how that kind of feeds into the formulation of the recommendations. So it's just to look at the kind of methods that are used. The first stage of it was to identify actually what the key questions that we want answered. They were identified and then kind of classified as what could be termed operational questions. For example, what should be involved in the initial response to an incident, who should have responsibility for leading the investigations. But also there was questions that were termed scientific, which were the questions that we're going to look at. What public health interventions could be used when there was an incident or an outbreak. Once we know the nature, that stage was important, because once you actually know the nature of the questions, it's only then that you kind of know what kind of evidence are you actually looking for. And then at that point, you use that to guide the kind of overall search strategy. So broadly speaking, there was 2 sort of stages to this. The first stage is you're looking for any publications from any key agencies. So you can identify agencies that might have produced any publications or procedural documents that are going to help. In particular, they're going to help with what were known as the kind of operational. So documents from, for example, Scottish Government Health Protection Network. You're also looking to Public Health England as well. So you look there first. You also look at international as well, maybe anything from Europe, ECDC as well. You also then look to see if there's any existing guidelines, anything out there that might help, or if they've already been done. And again, you're looking at things like there's a guideline international network, there's also NICE as well, and ECDC. So you do that, collect as much as you can. And from that, you're then asking what's there and what else is needed. You also look to see has anybody done any sort of literature search already on this issue. And if they haven't, then we need to do it ourselves. And that's what came about for what we termed the scientific questions. That is the questions that we're looking at. What public health interventions could be used for a spore-forming bacteria outbreak? So that was kind of the broad sort of outline of the search strategy. Collecting as much evidence as you can. For the last bit, scientific literature search, that has its own kind of search strategy, which I very briefly just want to go through. You use a very standard approach. You use this framework called PICO. You're using that to effectively help decide what are the search terms that you're going to use. It's a lot of search terms are used to help you define that. You're thinking about what is the population, what is the problem. Obviously the population was people who use drugs or people who inject drugs. But it's also useful to look at what the problem is, and the problem was dealing with outbreaks of spore-forming bacteria or incidents of spore-forming bacteria. You're then looking to see, well, interventions, what kind of interventions are out there? And you're very broad, everything needs to be quite broad at this point. So you're broadly sort of looking at what are the potential public health interventions, for example, that might be out there as well. So you're looking, you're looking to educational, behavioural, drug treatment, needle exchanges, outreach, health protection, anything. You're going broad for this effectively search for this information. Then comparisons. For us, we didn't have any comparisons, so that's not appropriate for us. And then you're also looking at outcomes. Outcomes ideally being things like, decreased mortality, decreased rate of infection, increased harm reduction uptake, increased harm reduction knowledge. Again, you're kind of going broad to trying to capture as much as you can that might help inform the guidelines. At that stage, you're not actually with outcomes. You don't use that within your kind of selection of the evidence, but that it will be used. It will be used kind of later on, as you'll see. So once you know kind of how you're going to search, you're then going to say, well, where am I going to search? And again, a very standard procedure is used. You're searching your bibliographic databases, looked at medical, nursing, psychological databases that are out there, reference checking. Again, you're also looking for guidance from the guideline development group members, of which some of them were academics as well as practitioners. You're looking for them about what their knowledge is as well, about any evidence literature that's out there. And again, you look at the grey literature and keeping it wide. All this that was done way back October, November 2013. But what you're also doing, because there's such a time lag when that's done to actually when the guidelines are produced, you always do a catch-up. So you're keeping up to date to see if there's any potential literature out there that might inform. But there wasn't anything. There was nothing new that came up. You also need to know what you want to include, so you have this inclusion-exclusion criteria as well. And again, a big long list is produced. But just to give you some sort of sense, obviously we're looking for any literature research that's been done with PWIDs or PWUDs. So you're going to include anything with them, but you're not going to include anything on bioterrorism or maybe occupational exposure. To, for example, like the anthrax with the postal workers. Your study types, for example, you look at the study types, you'll broadly look at anything. So randomised controlled trials, all the way down to qualitative research, but you'll exclude animal studies. And again, you'll look at the outcomes as well at that stage. So any study that's looking at maybe decreased mortality, decreased infection rate, or increased kind of harm reduction uptake as well. Okay. And what happens then? You do the searches, and broadly speaking, there was two questions. The first one was what were the public health interventions? What public health interventions can be taken to reduce the harms associated with potentially contaminated drugs during an incident and outbreak? So that kind of was one search, and then there was a separate search to kind of try and address the question: what advice and guidance could be given to people who use drugs during an incident and outbreak, and how is best to communicate this advice to this group. As you can see, it generates a lot of documents. And this is the procedure, it's a standard procedure that's used to effectively sieve through them. So the first screen is somebody who was me would read through. But very briefly, a lot of documents were kind of initially kind of found, and then what you need to do is to sieve through that. So there's kind of two levels of that, and well done. Thank you. That was easy. I'm going to keep my hands away from that. As you can see, a lot of documents produced initially, two sieves, and the documents that were actually used or referred to, there were only 10 in total. So at that point, you already know that the level of research that is looking at kind of spore-forming bacterial outbreaks or infections amongst injecting drug users is tiny, absolutely tiny. And if you broaden that out to actually look at sort of bacterial skin infections as well, there is not a lot out there. So in terms of that sort of body of evidence, it's limited. Then what you have to do is to assess that. It's a case, okay, we found it. But how good is it is the next question. And at that point, your guideline development group members are involved in appraising this evidence. Again, a very standard procedure is used. You're using all these checklists, sign a nice checklist to go through it. You're just asking the question, how robust are these studies, or how biased are these studies? So you do that for the kind of the research. There was one piece of guideline that was found, that also went up and was reviewed as well, but the problem with that one, it was in draft. By the time we were using it, it was in draft. And the guideline, the reviewers decided, because it was in draft, we couldn't use it or refer to it. But the beauty of that, the people who were involved in the development of those guidelines were actually, some of them were on our guideline development group. So that kind of knowledge was there. As much as we couldn't draw upon those guidelines, the knowledge was there. They were guidelines that were developed by ECDC, yeah. I'm not even sure kind of what state of play that they were at. So once you've got that kind of appraisal done, then everybody has to collectively just look at the evidence as a whole. You're looking at the quantity of the evidence, which we already know was low. There's not a lot out there. The quality was kind of variable. Some of the studies were of acceptable quality, but there were some of low quality. You'd also look at the consistency of the evidence. And again, the volume wasn't there, so there was no consistency. You'd also look at the applicability to NHS Scotland. And for some of these studies, you couldn't really draw upon the knowledge that was within these studies because they weren't necessarily applicable to Scotland, to our environment. For example, one study, the intervention was via a drug consumption room, which we know we don't have. Another study was looking at an American study. It was, again, different types of needles that were used. So as much as the evidence might have been there, it was actually, can we use it? And for some of those studies, the answer was no. And again, you're trying to generalise to spore-forming bacteria into an outbreak situation. And again, that kind of limited everything. There are other things that you look when you're doing your considered judgment, but really, by the time we kind of got to your generalisability, we're at that point, you're beginning to say, well, actually, there's insufficient evidence out there on preventive public health interventions that are really specific to spore-forming bacteria amongst the group that we're interested in, and also specific to outbreaks and incidents. So at that stage, there was very much the realisation that any of the recommendations that were going to be written up in the guidelines primarily were going to be based on expert opinion, rather than the actual evidence, the literature that was out there. So as Nora, when she's going to talk more about the guidance with respect to the interventions, it was decided to look at the interventions, or to present the interventions as routine, that's standard practice, and enhanced. And enhanced ones are specific to the spore-forming bacteria and outbreaks. And as I said, that is mainly based on expert opinion rather than kind of evidence as such. Okay, so that's my point where I now hand over to Nora. And I'll keep my hands away from this. Thank you.
So just moving on to the guidelines themselves. The first section of the guidelines is about the initial response when we become aware of a suspected case. So botulism, tetanus and anthrax are all notifiable, which means that by law they have to be reported to the public health authorities. So usually this will be by whichever clinician first comes into contact with them. So it could be primary care, A&E, and so on. So they should be notified to the local health protection team, who will in turn notify Health Protection Scotland. And at this stage, the diagnosis is usually just clinical, so there hasn't been any confirmatory microbiology at this stage. And as part of the initial response, the Guidelines Development Group recommends that health protection teams should ensure that the appropriate specimens are obtained for microbiology. Enhanced surveillance forms are completed and returned to HPS. And they should also undertake local awareness raising with clinicians and frontline workers on the signs and symptoms. So this is just really important so that everybody's aware and can pick up any future cases as quickly as possible. So I'm not going to go into this table, but this is just really to illustrate that the management and resources and communications involved differ depending on how many cases we see. So a sporadic case versus 2 sporadic cases versus a cluster of cases will all have a different response. So for 2 or more cases, the guidelines recommend that this is best managed by activating an incident management team, or IMT. And so this would include people from all the potential agencies involved. The chair would usually be the NHS board, CPHM. There may be other leads from other NHS boards involved. People representing addiction services and injecting equipment provision. People from the comms side of things. People representing microbiology. There will likely be epidemiology support from HPS, representatives from Scottish Drugs Forum and Police Scotland, and the Crown Office Procurative Fiscal Service if required. So the guidelines lay out the roles of all of the agencies that are involved in the IMT, and I've just highlighted 2 agencies here that I think are maybe potentially more relevant to this group. So the Scottish Drugs Forum, their role on the IMT is to provide expertise on drugs and patterns of use, to represent service users, to utilise their communication networks to disseminate public health information, to develop training resources for staff and awareness-raising materials for users who are potentially at risk. So injecting equipment providers would likely also sit on the IMT, and their responsibilities are to cascade information to frontline staff, as well as to cascade awareness-raising materials and facilitate discussions with their clients, and also to create referral pathways from their services into medical care. So the next section of the guidelines covers the epidemiological investigation. And so this sets out the case definitions, and I'm not going to go into great detail on these, but they differ for the 3 infections. But essentially, there's clinical criteria, epidemiological criteria, and microbiological criteria. So the clinical and microbiological are usually quite specific to the infection, and the epidemiological criteria is that the person has used illicit drugs by any route within the 2 weeks prior. So we usually classify a probable case as someone who has clinical and epidemiological evidence of infection, and a confirmed case, the clincher is usually the microbiology that comes back to confirm the case. So as part of the epidemiological investigation, we want to try to establish risk factors that could potentially identify other people who might be at risk and potentially inform any public health interventions that might be deployed. So there are enhanced surveillance questionnaires for each of the organisms. And in the guidelines, we recommend that the person who undertakes the interview and completes this questionnaire with the suspected case is somebody who is familiar with drug use. So this ideally would be somebody from frontline drug or addiction services. And this is just to ensure that we get the most accurate information possible, because our experience from previous outbreaks is that these are the best people to do this. So the next section of the guidelines covers the microbiological investigation. This isn't a very detailed section of the guidelines because it's mostly just signposting to other existing resources that sit within Public Health England or Health Protection Scotland on the diagnosis of these infections, which reference laboratories to send the labs to and to send the specimens to and so on. But what this does highlight is that the timeliness of the collection of clinical samples is important. So ideally before the administration of antitoxin or antibiotics so that we can confirm a diagnosis. But obviously we don't want treatment to be delayed. So moving on to the recommended public health interventions. Karen just told you that we went through this process of looking at all the evidence, and there was very little to actually underpin the guidelines. So much of these public health interventions are based on the expert opinion of the guideline development group members, and there was quite a lot of expertise around the table. So the interventions are categorized as routine or enhanced, And routine interventions are those that the guidelines group considered should already be the standard of practice. So these should already be being undertaken in services on a routine basis. And enhanced interventions are those that could be specifically deployed in an incident or outbreak situation specifically. So the public health interventions within the guidelines are organized into a hierarchy, and this illustrates the hierarchy. It is going from least risk to most risk. And so this is just reflecting the fact that in an ideal world, we would tell everyone to stop using drugs, and they would do that because this is really the only way we can ensure to eliminate the exposure of spore-forming bacteria. But pragmatically speaking, this isn't going to happen, and the group recognized that the nature of drug use is that people will continue to use even when they are warned about the risks. So if we can't reduce or eliminate drug use, the group would recommend switching to a safer use of drugs. There are a number of interventions falling under the category of reducing the harm among those who continue to inject drugs, and I'll go into all of these in more detail. And finally, for those who have become infected, education and awareness raising of the signs and symptoms of illness is really important to ensure prompt treatment, because the sooner you get treatment, the better your clinical outcomes. So there are about 22 or so recommendations in the guidelines, and I'm just going to highlight some of these today. So under the theme of encouraging people who use drugs to reduce or eliminate drug use, the Guidelines Development Group recommends that services providing OST or opiate substitution therapy should be reviewed and enhanced in order to maximize coverage. And the rationale behind this was that specifically in outbreak situations, it may be possible to reduce or remove waiting lists, to review eligibility criteria, and so on in order to maximize OST during that outbreak period to reduce risk. Under the theme of encouraging people to switch to a safer route of drug use, so the Guidelines Development Group recommended that people should be encouraged to switch to a non-injecting route of drugs. And this was only in the case for botulism and tetanus, because, as I said, with the anthrax outbreak, we couldn't eliminate the association with smoking or snorting drugs. And the rationale for this is that smoking is lower risk than injecting. And this is because injecting introduces the bacteria directly into your bloodstream. And also the skin and soft tissue damage that a lot of people get from injecting frequently provides an environment that's quite conducive to the growth of these bacteria. So it's innately higher risk for this reason. So under the theme of reducing harm among those who continue to inject drugs, within the context of an outbreak of tetanus, the group recommends that low threshold services should be enhanced, and every opportunity should be taken to vaccinate people whose status is unknown or whose vaccination is incomplete. And this is sort of a pragmatic recommendation because the group recognized that you wouldn't achieve immunity if somebody had no vaccination. Through a 5-dose schedule, you wouldn't achieve immunity during the time frame of an outbreak. But nevertheless, it should be something that people do anyway, because there could be some people with incomplete status whose vaccination could be brought up to date and thus reduce the risk of infection with tetanus. So also under the theme of reducing harm among those who continue to inject drugs, the first two of these are already part of the Scottish IEP guidelines, and the Guidelines Development Group just wanted to highlight these because of their applicability to spore-forming bacteria in particular. So the Guidelines Development Group recommends that PWED should be encouraged to minimize the use of acidifier for mixing with drugs. So this should be done on a routine basis within services. And this is because using too much acid can devitalize the tissue. So it's again about creating the conditions where these spores are more likely to germinate and more likely to cause infection. The guidelines group also recommend that PWED should be encouraged to wash their hands before preparing drugs. And there was no evidence that specifically in relation to the spore-forming bacteria But the group felt that good injecting hygiene was something that we needed to emphasize, and also that it could reduce the potential for the other more common staph infections that can arise. The group also felt that PWD should be discouraged from injecting into the muscle and into the skin. And this is for the same reason. So we've seen associations with this kind of injecting into the muscle or skin or muscle popping, associated with botulism and synoviae and so on in previous outbreaks. So reducing that will reduce risk. So under the theme of education and awareness raising, firstly, among people who use drugs, the group recommends that information on the signs and symptoms of illness and guidance on when and where to seek medical care should be communicated to users. And the rationale for this is just because people should know what the hazards that they face, but also that, again, it's really important if people do become infected to get them treated as promptly as possible, because this can improve their outcomes. So in terms of education and awareness raising among professionals, the Guidelines Development Group recommends that IEP and addiction staff, so injection equipment provision and addiction staff, should receive training on the clinical presentation of these three illnesses, and that this should be done routinely. And this is because people who use drugs regularly come into contact with these service professionals. So these people are ideal to recognize the signs and symptoms and to help facilitate medical care. As an enhanced intervention, the guidelines recommend that during an incident or outbreak, interventions to heighten and maintain awareness of these clinical presentations should be undertaken with these same groups of staff. And the rationale for this is because we don't see very many of these infections, so people aren't very familiar with them, even if they have received training on them. So it's just about refreshing this in an incident and outbreak situation. And finally, for clinical staff, the guidelines recommend that healthcare professionals should be made aware of the appropriate diagnostic procedures, including these samples to be obtained for microbiology prior to treatment. So we are very nearly there with the guidelines. Essentially, they're still officially in draft stage, but what they need just now is just final sign-off by the Guidelines Development Group. After that, they'll go to an extended consultation, which is part of the process of the Health Protection Network Guideline Development Program. And after that, they'll be edited and published. So if anybody has any suggestions for the stakeholder groups in terms of the extended consultation, then please feel free to email me at nora.palmateer@nhs.net. And this is just to acknowledge all of the people who are on the Guidelines Development Group. Thank you.